Here we are. I'm going to be scoring a record. I keep getting people, mostly technologists, are like, hey, buddy boy, would you score a record for us so we can see what's going on? And typically I say no. But it's going on right now. So this is my, doing some background real quick. This is my newly designed website. It is gorgeous. Put a lot of work into it and I finally got it out. But on here is sleep stages. So if we're going to be scoring, you need to know a little bit about sleep staging. So here is wake with eyes open. These are all things we're going to be looking at it as we score this record. So this is called alpha here. Alpha is 12 hertz cycles per second. So this person has their eyes shut and they are not asleep as of yet. Then we have stage 1 or N1. So something to look for in stage N1 is these vertex sharp waves. That kind of looks like one. Usually you get these slow rolling eye movements and the mixed voltage, mixed frequency, low amplitude frequency here. Normal chin tone. That's it. Stage 1 N1 sleep. Then we have N2 sleep. Comprised mostly of the night, usually 50% of the night. So you have these sleep spindles here. Those are 8 to 12 cycles per second. Then you have the K complexes, sharp negative followed by a sharp positive. Negatives up, positives down. So that's stage 2. Again, 50% of the night and most people. Then everyone's favorite, woohoo! We have delta, slow wave into. So you can see the big, high amplitude, slow waves. That to be at least 75 microvolts in amplitude. And then they're like a half a second to 2 seconds long. This could be a very slow video. I'm going to take my time doing this. I'm going to do it right. I'm not cutting away at all. You're going to see just how painful it is to be a scorer. If you're a sleep tech and you want to be a scorer, you know what? I'll line them up because you do these like 8 a day. They're long. 6, 8 a day maybe. Your wrist kills. You get line fever from looking at this stuff all day. Then you come back, do it the next day. So here it is. All right, so this is REM. You have the chin that drops out, eye movements. A lot of times you'll get these big delta-looking waves in REM, but clearly this is REM. Again, no chin. Something that's also indicative is sawtooth waves that are theta waves. They're 4 to 7 cycles per second, or 4 to 7 hertz. I don't see any on this page. I believe I have one in another sample somewhere. Here it is. See, the website has everything. There's theta, so 4 to 7 looks like a saw, like sawtooth, so sawtooth waves. Clever, yeah. So there's no big eye movements here, but typically you'll see the sawtooth waves like right at the beginning. So that's probably right at the beginning. All right, let's go ahead and score. Woohoo! So I already have one pulled up. So this is actually from my home sleep test. It's a type 2 test, so it does have EEG, which is brain activities, brain waves. Actually has everything. I'm going to get rid of some of these channels I don't need. I'm going to talk a little bit, then go kind of quiet, and I'll be a little quiet sometimes, trying to explain things because I am actually working. So left eye, right eye, we have the chin, looking for tone in that. We have frontal lead, that's front of the head. Then M1, M2 is actually behind the ears. Usually used as a reference, but I'm actually using it to pull out like sleep onset. It helps me out with, but typically that's seen in the occipital channels, which is O1 and O2. So then I have the P flow is the nasal cannula where you're breathing. It's a PTAF. It's a pressure transducer. It's like I said, the cannula that goes near your nose. The THO is the thoracic belt that goes up around the chest. And then you have the abdominal, which is around your gut, your belly. So we use those two to differentiate between central and obstructive apneas. We have the EKG, which is your heart. Then we don't have, we're actually not using legs. Those are legs though, but so normally you'd use legs. Nothing to see here, no legs. So the NS stands for not scored or not staged, something like that. Hey, you know what? I don't know. So wake. You can see all these big eye movements up there. You can see it's all thick and crappy. So that's awake. So right now they're just looking around, trying to get settled. All those little thingies right there, those are blinks. See those? That's blinking. All those are blinks. Starting to calm down. You can see that there's still blinks, but the EEG is actually thinning out. That means there's less tension. So the first time I go through, I have it on the 30-second page or an epic. And what you do is you stage. So it's 0 for awake, 1 for stage 1, 2 for stage 2, 3 for delta or stage 3, and 5 for REM. So we can't really mark any respiratory events until we actually have them sleep staged. So we have to do that first. So this is still awake, and I know it doesn't look anything like the alpha that we saw earlier. But you'll have to trust me that everyone's different. And so what we're trying to do is determine a sleep onset, and so you can see that's kind of thick. And you see the line right there, looking a little too fast. As we scroll forward, now you can tell that it looks much slower right there. Here to here, slower there. So I'm comfortable with calling that stage 1 and sleep onset. So we're calling that 1. I'm going to throw in a reference line so I can see if delta comes or if and when it comes. Still haven't really seen a good K-complex or spindle to indicate stage 2, so still stage 1. That slow rolling eye movement is indicative of stage 1, so we're keeping it stage 1. And that's what we're doing. Getting close to stage 2. So right here we have like a weak K complex. So sharp up and down, sharp negative and positive deflection. Happens right before the 15-second line, so the majority of the page would be stage 2, except that she wakes up, except for the patient wakes up right there. So what we're doing is we're keeping it stage 1, then an arousal, so wake. Then we go back to stage 1, and then 2, because there's a big old fatty K complex. So we're at 2, and there's the patient wakes up again. So wake, 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 wake. You can see in there's more blinking. You can see all the blinks down in the EEG as well. The frontal leads are like right above the eyes, so it's right on the hairline, and it'll pick up eye movements. It's not going to be picking them up in the M1 and M2 because they're back behind the ears, more on the hard skull. So in a real sleep lab, you're not going to be using M1, M2 other than as a reference. But here you can, I need to eke out as much as I can. All right. It's all about maximizing your channels. So we have woke up, fell asleep for a little bit, right there, woke up again, and now back to sleep again, and awake again. So awake, awake, awake. Ah, the life of sleep disorders. Wake, 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 wake. I'm going back one. It looks like that is M1, M2 is a little funky, so I'm going to ignore that just a tad. It might be getting pulled on or something, but you can still see that the frontal channels are clear, so that's good. So we have another arousal there. Has to be 3 seconds or longer, and that definitely meets the criteria. Back to sleep right away. So that's stage 2. You can see the K complex early on. Or 2, 2, 2. Some of the waves are starting to get kind of big. Amplitude wise, but you can see that there's a lot of waves and they're pretty slow. Shouldn't that be delta? Nope, nope, nope. It has to be above the line because that's a positive 37.5 and a negative 37.5, which equals 0.75 microvolts. Blam! And it's not high enough, so it's not going to count. So there's wake. So you have stage 2 up to there, and then you have wake for the rest. So majority of the page is awake, so you call it wake, even though there's some sleep on it. Then we immediately go back into 2 because right there we have a K complex. I think you probably get the gist of it, but again, that's stage 2, and you can see it's like to the 16 or 17 second line, so the majority of the page is 2, and then there's another arousal, and then right back into 2, so it'd be 2, 2. But see, if you expand the view, you can see that that is an event, and it thickens the line. The EEG line thickens as they wake up, and it corresponds with the arousal, or with a respiratory increase. And so, you know what? I should stick with staging because that's what we're doing right now. So, stage 2. So that looks like that's stage 3. We'll give it the benefit of the doubt. You need 6 seconds because that's going to comprise 20% of the page. And that's what you need for delta. It's just a random thing someone thought of. Hey, 20% of the page is delta. There we are. So we're kind of bouncing around between 2 and 3 right here. So we're kind of going back and forth between 2 and 3 still. Then an arousal. And 2, 2, 2, 2, 2, 2, 2. So if you're curious, you can look up at the very top of the screen there. You can see that black line right there is stage 2 as I'm scoring it, and the line at the very top is wake, and then 1 would be like halfway in between the 2. You can see how it's scrolling along the top. So I'm at like 3:15 a.m. I'm sorry, 2:15 a.m. So there's some delta in here, N3. So here's the top I'm showing you, that black line right there. Hopefully you can see it. That's wake. We have kind of the thicker, this little tiny line there is 1, and then the bigger line right there is, the red line is 2, and then that gray bar at the bottom is 3. So you can see right there I'm doing 3 right there, right there, right there, right there, 3. Since I know every page looks like it says NS, actually some pretty nice delta there for a bit too. Then we got wake, and sleep, 2, 2, 2. Then there's wake again. So wake. So all you people, like if you're a technologist who's working the night shift and you're just dying to come on to days, night shift work is so much easier. It is not even funny. Yeah, it's tough when you're hooking up the patients and you got like, wait, hold on, wait. See the chin there? Chin tone is up. We have room. I'm going to increase it just a bit so we can see it better, hopefully. So we have stage 2. And you see how it's a little lower again. And then right there we have eye movement. I don't see theta, but you can see that one sharp eye of movement with the chin dropping out. Then you have low voltage mixed frequency in the EEG. So right there is much more clear. You can kind of see it come on. A lot of people go, oh, it's not REM, but you can totally tell when it comes on. So now this is very, very clear. So what I was saying anyway, if you want to come on to days to score, you're actually busting your butt all day long. You're scoring records, you're seeing patients, setting people on auto sets, doing mass fittings, that kind of thing. Handling equipment, cleaning equipment, troubleshooting problems, ordering new supplies, making sure that just, doing everything. You're even doing laundry. Yes, laundry. Yes, it's a glorious job. At night, you attach some electrodes. It's crazy for 2 hours. Then you read a book, open up your laptop, fart around, monitor a patient, add CPAP. But seriously, other than staying up all night, it is easy. And it's true if you've done both. It's true. All right, so we have some wake here interspersed with some 1 and 2. So I'm sure when we look at this later, there's going to be some sleep distorted breathing in that time period with a wake one, but we're not quite there yet. We're getting close to the end, but we got a ways to go. So I've got a bunch of stage 2. Now, if the guy that does the, you know what? if you ever score from home, you're going to notice that your 1 and 2 button get worn out really fast when scoring. Probably some delta in here. It's getting slow. So I was going to say, there's this dude that scores for the inner score reliability, and he keeps coming on all my videos being a butt because he thinks he knows it all. But guess what, old buddy boy? People complain about you all the time and how horrible your quote-unquote gold standard scoring is. So if that's you, we'll call you Mr. C. You know who you are, Mr. C. You might want a little bite of humble pie there, buddy. So usually staging these is easy. It's the easiest part. And the rules are rules, so you follow the rules. So we're plowing through this. Looks like we have a little more REM onset starting here. So we got 2-2. And then right there is, see that pinchy eye movement? It's 2, chin drops out, and then the eye movement is right there. I like that eye movement. And so I didn't see any theta, so we're going to go by that eye movement as the onset. So here we're REM. You know, and if anyone tells you that they can tell you what you're dreaming about, they're full of le poo. You can't tell anything about someone's dreams by looking at this stuff. And all that dream interpretation stuff, you know who can interpret your dream is you. So then we actually do a back REM. Keeper in REM. iCloud storage full. Nice. All right, keeping them in REM. REM. So you can see that big red line up at the top. That's all REM. Never mind the NS, it's all REM. REM. So we're going to keep her in that until there's a clear arousal or stage change. And an awake. So when you see those big arousals that last the entire page, that's an arousal. This is all just wake. I think she is going to be done for the day. She's wondering, what is all this crap on me? Like I said, this is my home sleep test, so she has all this stuff on her. People usually wake up and go, what the hell's on me? And then they go, oh, that's right. That's that friendly guy from California, where I saved a ton of money on his home sleep test. Wake. Oh, again, axgsleepdiagnostics.com if you're curious. Quite a clean recording. They're hooking themselves up with this. I have a nice, easy to follow instructions. She does go back to sleep just a bit. Could be, yeah. She is trying to go back to sleep, so there's some sleep. Most of it's wake, though. Usually when people are done sleeping, especially with a sleep study, they're kind of done. You got a bunch of stuff on you. So you see how those are kind of central in nature. A lot of you people who use Sleepyhead will notice, like in the early morning, you have a lot of central apneas. It's this kind of stuff, kind of in and out of sleep. Respiratory drive is a little funky, and so you'll see those central apneas manifest. Normal, not something I'd worry about, or no need to call your pulmonologist or neurologist. It's when you see them throughout the whole thingy, throughout the whole night. So what we're going to do, head back to the beginning of the study. So we don't care about all this stuff that's wake. Remember, it is a sleep test. It is not a wake test. Don't care much what people are doing when they're awake. So we're looking at the sleep. So now what we're doing is we're kind of focusing on the respiratory. We scan the EKG. I scan it, make sure there's no PVCs or PACs. Any abnormality like that. But I'm mainly focusing on the respiratory and those sinusoidal channels. So I scan up there and I look at the EEG, to see if there's anything that correlates with an arousal. So just because that decreases doesn't necessarily mean that there's an arousal. Also have the SpO2, so I'm looking for desaturations and how it all relates to each other. So just because that dips right there doesn't mean that there's an arousal. I don't see any difference between the two. No concern. So I take a closer look just to make sure, and that's it. And that's not an arousal. It's simply not fast enough. So you kind of get an eye for it once you do it for a while, and you see what's wake and what's not. Like right there is probably something. You can tell the thickness of it. You can see the frequency right there. Even though we're looking at it in a 2-minute window, you can see that there's a difference between that and that. You can see how much thicker that is. And it corresponds and correlates with the decrease of the respiratory effort and respiratory signal. And you can like draw a straight line from the respiratory channels up to the EEG. Then you also see 93 to 92. Not much of a desaturation, but it is a clue to it. And you can kind of see on the next one that it's doing the same thing. So that's a RERA, respiratory effort related arousal. And we have kind of the same scenario right there. Same scenario. So it looks like got another one there. I don't see a desaturation that's enough to call it a hypopnea. If we get a bigger desaturation, that'd be hypopnea. It's like a 4%, but starting right there, building up respiratory effort related arousal because there's an increase in effort prior to the arousal. I feel like I'm just doing like free flow consciousness, like I'm just talking without really knowing what the hell I'm saying. So here's another. Today is RERA day, apparently, all day RERA day. So right there is a post-arousal central. I'm not going to call that anything because they're just falling asleep right at sleep onset, and sometimes, actually, you know what, it's not long enough anyway, which is now the new reason why I'm not calling it anything. But typically you have a post-arousal. Yes, it's sleep, but it's like a sleep onset event. If it were to persist, I'd call it one. Yeah. You see a few centrals sometimes, people get freaked out, but oftentimes it's like a post-arousal central where you snore, sigh, cough, sneeze. You'll get one of the central apneas after a position change too. So a lot of RERAs in here. Well, not a lot, but a few. That is just a plain old arousal. Just woke up for no apparent reason. There's no building in the respiratory channels, no decrease in it. Just to clear an arousal. Now this one looks a little different. You can see how that one builds up to it. It has a different look. Hopefully you can see that. So this is all delta. In the lab, what you notice is in delta, breathing disorders kind of go away, even in people with severe apnea. You get into delta and all of a sudden it looks good. Bad part is sometimes you can't get into delta if you have really severe sleep disorder breathing. But when you do, it's interesting that it's minimized. Do I know why? Not really. Not really. Sleep here is actually pretty well consolidated. Just on the patient is on their left side. So, you know, it could be that they're positional. I don't know. We'll see later. There's a little shift there in EEG. It looks like maybe a little arousal. Change these channels a bit. I'm trying to decide if that's a RERA or not, and I'm leaning towards not. That one I'm leaning towards yes, because it kind of looks that way. That one does too. So you have to look at the belts also. Not much of a desaturation to speak of, but you can see that the nasal cannula signal on the top there and the ones below at the belts are all kind of decreasing and then increasing at the same time with an arousal associated. So it's really subtle, but it's certainly there. So it's a 2% desaturation on that one. Here's another one of those situations like a sleep onset central. Again, I'm not going to call it anything. It's just a bigger arousal prior to. I'll call it an arousal, but I'm not calling it a central. Like you're probably looking at this one saying that's something and it's nothing. There's breathing in there. There's no arousal, so it's, by definition it can't be anything. So now we're into REM. Here, let's see. Super close to being a hypopnea, but the saturation isn't enough, and there's no arousal, so we're not really going to call it anything. That one is a desaturation, so we will call that a hypopnea. Now, if you're a sleep tech and you've been scoring for a long time, save your hate mail. Again, I don't want to hear it. I don't care how you score. If you do, you record your own scoring video and do whatever the hell you want with it. But if you want to send me some hate mail or you're not doing it right, go for it. So look at it for a half a second and then you're dead to me. All right, so here's a longer hypopnea. This is in REM. Pretty good size. The saturation looks like 5%. You see it comes up 3% after that. So that's a clear hypopnea in REM. That's kind of normal for sleep disorder breathing to be a little worse in REM. Maybe a little REM specific there. Possibly positional too, because now this patient is supine and there's the resumption of sleep disorder breathing. We'll have to see on the report. I'm not going to do the report on this. Anyway, back to that. I don't understand people that want to complain about what other people are doing when they're not doing anything themselves other than complaining. It's bizarre. So either do it yourself or, yeah, your criticism really isn't welcome on a lot of this stuff. Just looking to enlighten people, show them a little something, whether you're a technologist or a patient. See something you're not typically going to see. Maybe learn something from it. Just seems like the nice thing to do. I use YouTube all the time. All kinds of home improvement things. Love YouTube. Plumbing, a little bit of roofing. Some landscape stuff. And we got some RERAs here. So just because you may think there's no value in these videos, doesn't necessarily mean someone else doesn't find value in it. And if you think you could do the video better, do it better. I saw some guy fixing a refrigerator, and he probably thought it was stupid, or other people might think it was stupid, but when my refrigerator was jacked, I opened it up, fixed it in about probably 15 minutes after watching a video and, get buying the parts and stuff. But it's cool. It was awesome. So anyway, I like to do it too, because hopefully this helps other people understand sleep. Another thing, I couldn't get my key to start in my car, like it wouldn't even turn, and I tried the whole turn the wheel and then turn it, and nothing. It was totally stuck. So this video, I called AAA. I had my mother-in-law was gonna come out to pick me up. Oh God! And then what this video says is slam on the key with the palm of your hand while you're turning the wheel, then turn it. And it started up like a charm after looking it up on YouTube. Crazy. So anyway, I like doing these YouTube videos, sharing things that some of the stuff, it doesn't even seem like it's a big deal. But like anything, if this is my world, so I know a lot of stuff in it, but it doesn't mean everyone knows it. There's a 5% desaturation, decrease in airflow in REM. That is a hypopnea. say, hey, I encourage you. If you have something that you do, and you just film it and show people, share it, help someone out. Another hypopnea. And that one is just a RERA because the desaturation isn't enough. It was like a little 2%er. And there is another RERA. So there's this big period awake. No idea how long this video is taking. I typically don't talk, so I have a feeling this is longer than what it usually takes me. Or hold on. Yeah, I gotta call that. God, I hate these. I don't. Blah, blah, blah. So yeah. Anyway, that's it. That is a scored record. There's some other things that are involved that I don't want to bring up the patient's name and show the report, but so it looks like it's taken 31 minutes to score this record. Pretty good time. Not really a lot of difficulty in this one. No leg movements I'm doing, so it went a little faster. But typically, it'll take like 45 minutes or so. If you have any questions or comments, please feel free to make them, because you know what? People make comments anyway, so I guess I can't stop you. If you want to join the forum, hopefully you got something out of this thing. Anyway, if you want to join the forum, you can go to the freecpapadvice.com, go down to the forum. Hold on. So that was my home sleep test. So I have a little thing here, some videos, compares different types of sleep tests. What I just scored was the sleep test that I do right there. If you want a home sleep test with EEG, you can go to my website there. $459. I know that's not cheap, but compared to an in-lab study, it's pretty cheap. And as far as what you get comprehensive wise, it's much better than like a type 3 and a type 4 test. Mine is a type 2. Anyway, my website, freecpapadvice.com, full of all kinds of helpful tips and stuff. Use it. Ask me for new content. I'm happy to put it up. I love putting up new stuff. Anyway, once you join the forum, you can join the forum, ask questions, learn about sleep disorders, treatment of sleep disorders, how to get the most out of your CPAP therapy. We have quite a great crowd. A lot of questions there. A bunch from today. That's pretty much it. Anyway, so scoring's fun. I enjoy it. I get lost in it. It's like a little mystery every time. Try to figure out what's going on, make sense of it. Be a little intuitive. There's a little bit of science, a little bit of art. It's fun. I enjoy it. All right, I'm going to end this long video. It's going absolutely nowhere. So, thanks for dropping by, buddy.